Okay, hi everyone. Thank you for being here today. My name is Lexi Day, and I'm currently a graduate fellow with CRISP. Today is the last of 4 webinars related to the Maryland Model Analytics project. For some background, this project set out to evaluate specific aspects of the Maryland Total Cost of Care model and care transformation efforts. CRISP sent out an RFP and contracted with multiple vendors and stakeholders to address investigative analysis questions regarding aspects of care redesign, potential best practices, and areas of improvement for future consideration. Today's webinar will explore differences in 2019 per capita costs of care between counties in the Baltimore area and other urban counties in Maryland, before and after risk adjustment for patient complexity. We do ask that you hold questions until the end of the presentation, but feel free to put them in the chat. With that, we have Sean McClellan and Osvaldo Urda Pieta today here from APT. They will be presenting on healthcare costs in Baltimore relative to other urban areas in Maryland. So Sean and Osvaldo, whenever you're ready, you can start.
Great, thank you so much, Lexi. Good morning, everyone. My name is Sean McClellan. I'm a health services researcher and senior associate at APT Associates. And I'm also the project director of the contract with HSCRC, the Maryland Health Services Cost Review Commission, under which this study was conducted. And we're excited to be presenting findings from our study, as Lexi said, on healthcare costs in Baltimore relative to other areas in Maryland.
Hi, my name is Osvaldo Rapilleta. I'm from Optimal Solutions Group. I'm a health service researcher and a principal associate.
Osvaldo, I think if we can move to the next slide, please. Thank you so much. So as mentioned, this work was done under contract with the HSCRC. We'd also like to make a few acknowledgements to Peter Hallam and Mark Franklin at Milliman for preparing the underlying data used for this study, and also doing a little bit of ad hoc analysis during the study for us. And also to Stephen Bronnell and Reed Bursick of the SAG Corp for conducting a lit review. And with that, let's dive in. Thank you so much. So as I'm sure many of you know, the Maryland Health Services Cost Review Commission plays a vital role in the implementation of the state's all-payer rate-setting program going back to the 1970s. And this system, which initially focused on rate setting for hospital services, aims to reduce per capita expenditures and improve health outcomes. Now, recently, Maryland has implemented 2 value-based payment models to expand these efforts. One is from 2014 through 2018, the Maryland all-payer model, or MDAPM, which, in partnership with CMS, established global budgets for hospital services. These hospital services can include, in contrast to previously, both outpatient and inpatient services. So this model successfully reduced costs and improved the quality of care for both inpatient and outpatient services. Starting in 2019, Maryland also began implementing the total cost of care model, which includes new opportunities for non-hospital care providers to participate in care redesign and receive value-based payments. So our presentation today was motivated by this background and also by some descriptive analysis that the HSCRC conducted, which identified potential differences in costs of providing healthcare in the Baltimore area relative to other urban areas in Maryland. So in the presentation that follows, we will describe findings using data from 2019. This is pre-COVID data. So we have 2019 data from a more detailed analysis assessing differences in per capita costs of care between Baltimore area counties and other urban counties in Maryland. And we also do a few other adjustments. We look similar to benchmark communities in other states for both of these areas, and we also look before and after risk adjustment for benefit generosity and patient complexity. And I'll now turn it over to my colleague Osvaldo for an overview of our methodology.
Thank you, Sean. I'm going to provide a little bit of an overview on the methodology. There's a lot more details in the report. Some of them we have even other reports that refer to the methodology. But let me go over the overview. The cost and and utilization analysis were based on 3 measures. I want to make sure that we remember those 3 because we're going to be using them all along the presentation. Unit cost, utilization RVUs, and the total per member per month allowed cost. Now, we use these cost and utilization measures for the Baltimore area and for Maryland urban comparison counties that we refer them as the non-Baltimore area. And I will discuss on the next slide what counties were used for that analysis. Then we compute these cost and utilization measures for 2 out-of-state benchmark communities that have been used through this study too. In total, we computed the 3 measures for 4 geographic areas. So we will be doing comparison of these measures and kind of testing differences against each other to the entire presentation. So you will see the tables repeated over and over, but this is for different analysis and different measures and different geographic areas. Now, a little bit on the methodology. To compute the cost and utilization of Baltimore relative to the Maryland urban counties and to the external benchmarks, we did 3 comparisons. First, we compare the Baltimore and non-Baltimore areas, and kind of that's the most basic part. And the question that we will be answering there is healthcare less expensive in Baltimore than non-Baltimore urban areas? Plain and simple. The second one is compare the cost and utilization of each Maryland area to the corresponding benchmarks. The question that we will answer there is healthcare in Baltimore less expensive than the cost in a nationally comparable geographic area with similar demographics? Lastly, we computed the net difference between Baltimore, Maryland areas and their benchmarks. In these calculations, we can learn whether Baltimore healthcare is less expensive than nearby Maryland urban areas once we take control, once we control for healthcare costs and utilization of other similarly constructed areas outside of Maryland. This could also be taught as a difference in difference type of calculation, which is kind of the bottom line that will be used for the rest of the analysis. There's a very interesting component of our analysis is that once we calculated the relative difference in the total allowable per minute per month to the benchmarks, we decompose this difference into 2 factors or drivers. The first is the difference of the unit cost and the difference in the utilization. And this is kind of a method that was developed by the team. We have kind of a footnote on the presentation and a report that kind of goes more into detail how to compute it. But with this approach, for example, we can establish whether utilization differences are the driving factor to a potentially higher total allowed cost per month in Baltimore, for example. So it's not only is it higher, what is the drive factor driving it, unit cost or utilization? So that's pretty interesting. The next slide will kind of discuss now the 4 geographic areas for the analysis. First, we had to define the Baltimore area counties. What is we define that the area that we're observing higher utilization, higher cost. And for that, it was selected Carroll, Baltimore, Baltimore City, and Hartford. This selection of these 4 counties was done in collaboration with the HSCRC, and these counties are shown here in yellow in the map. Now, to identify the comparison urban Maryland urban area, we look first at what are the Baltimore counties that we have in the map. Well, for example, we have Baltimore City, which is the most urban area in Maryland, and because of that, we did not want to use any nearby rural areas. For example, you could see that Howard County is a smaller and more rural area, a more rural county than all the other counties in the Baltimore group. So we did not include it as a comparison. What do we use then? In the second group, the non-Baltimore area, we have a set of counties that have similar geographic characteristics, including measures of population, population density, and median income. With these characteristics, we selected Montgomery, Prince George, and Allendale as the non-Baltimore area. All of these counties are shown here in the blue. And lastly, we constructed a benchmark community that is like each of the Maryland and the Baltimore area. So we construct 2 benchmark communities that are similar in the aggregate on similar characteristics: population, population density, average healthcare prices, case, and payer mix. So all of this is to compare them and to create a net difference, a difference in difference analysis. The benchmark communities were each of them a function of 20 MSAs outside of Maryland. For example, the Baltimore area might be matched to an MSA like Detroit and Los Angeles MSAs. So it could be a combination of those. Again, we have more additional details on the development of the benchmark, of the methodology in a separate report. So for these purposes, we're kind of taking as granted, but I'm pretty sure that if you have any questions, we might try to give it a workshop today. Next is what do we do for measuring costs and unit analysis? So one thing that we want to discuss here is what is data that we use? And I think that Sean described a little bit what kind of data we have. So for the 2019 data sets and the proper definition of the cost and the utilization measures, we cannot describe that we use the Milliman Consolidated Health Cost Guidelines Sources Database, CHD, and the Maryland All-Payer Claims Database. All of this for 2019 to measure healthcare costs and utilization for the commercially insured patients. Then we want to make sure that making that distinction, because later on we'll have a brief conversation about Medicare fee-for-service. So the three measures again for the analysis are the average per member per month allowed cost, the average per member per month RVUs, and the average per member per month unit cost. So these three are combined, and as you can expect, the average per member per month allowed cost is going to be a combination of the product of the RVUs and the per member per month unit cost. So in the focus of our analysis, and when we talk about the differences, we'll concentrate on the total allowed cost. Just to note here that for purposes of the averages, we use population weights for each of these measures. Then let me go to how do we analyze this cost? Well, we think that there are many ways to present the cost analysis, and we use three profiles. Each of them profile a consistent story of the difference in total allowed cost between Baltimore and non-Baltimore areas. And Sean will show you a little bit more of that. The main basic cost profile is unadjusted allowed cost. It's just pretty much straight, no adjustments, whatever we found from the data. Then we use two other profiles of total allowed costs for a comparison of the populations with similar health status and plan benefits. Our intent with these two profiles is to kind of have a comparison of apples to apples. The second profile, the one we have here, is the risk score adjusted cost. In this case, we adjust total allowed cost for difference in the hierarchical condition category scores. In the third analysis on the third profile, we allow cost adjusted for difference in ACC scores, but also in an insurance plan benefits level. Why? I think that we include the benefit level because generosity in coverage of commercial insurance plans may lead to changes in utilization and thus in total cost of care. So this is one of the most important. And as you can see for the rest of the analysis, except for a first explanation of the unadjusted allowed cost, will show you we concentrate on this particular profile. Now, what happens after we do these differences and we identify costs? What the difference on total cost is. Then we assess the total cost and this by subgroup and subline item. So we drill down on each of the major group line items, such as facility inpatient, facility outpatient, and professional services. Depending on what is identified as the major group driving cost differences between Baltimore and the non-Baltimore area, of course, after controlling for the benchmark areas, we drill down into the subtotal line items for each of these group items. So for example, we could pinpoint here the main potential drivers of cost difference between Baltimore and non-Baltimore. Lastly, we also do a similar analysis for Medicare costs using Medicare fee-for-service claims. We really discussed this at the end of the presentation. So now I turn over the mic to Sean for the presentations of the findings.
Thank you so much, Oswaldo. As Oswaldo mentioned, the first set of findings here that we're going to cover are about the employer-sponsored health insurance population. And so we're going to move forward with that. So this exhibit is representative of the exhibits that we really use in this study. And we'll show it graphically as well, but I just want to walk through this table structure so that we can be as clear as possible. So this exhibit shows differences in the total allowed cost between the Baltimore and non-Baltimore areas overall, And I'm sorry, for the Baltimore and non-Baltimore areas, and for in the rows there, and then the difference between those two areas. And it also shows in the columns unit costs on average for each area, utilization for in terms of RVUs for each area, and total allowed costs on a per member per month basis for each area. And so what we see here is that in the Baltimore area, total allowed costs on a per member per month basis were $375.81, about $376, and unit costs were about $57. In the non-Baltimore area, we see numbers that are a little bit lower, but in the same ballpark. We see total costs, total allowed costs per member per month of $329 and unit costs of $53. Accordingly, the difference in average total allowed cost per member per month between these two areas was about $46.42. And you can also see, unit cost average differences on average of about $4 and utilization differences of about 0.4. So according to this table, both unit costs and utilization are slightly higher in the Baltimore area, resulting in total allowed cost per member per month that's a little bit higher in the Baltimore area. So now we'll move on to the next slide and add a little bit of complexity. So this slide is a little busy, but it has kind of follows the same structure, adding in average unit costs, RVUs, total allowed costs for our benchmark area, as well as the difference between the Maryland areas, Baltimore and non-Baltimore, and the benchmark areas. And that's ultimately going to be our metric of interest, which is kind of in this, the area of the chart that has the black box around it. And so what we see here is, so we have, again, in the Baltimore area, in Maryland, we have total allowed cost per member per month of about $376. And in the Baltimore area benchmarks on average, we have total allowed costs of $396. So the Baltimore area was actually about on average, on a per member per month basis, about $21 less expensive than the benchmark areas. Similarly, the non-Baltimore area was also less expensive than the benchmark areas for those counties by about $65. And so after netting out this difference, we still see that the Baltimore area is relatively more expensive than the non-Baltimore area relative to the benchmarks. But it's important to emphasize here that both areas were less expensive than the benchmarks. It's just that the Baltimore area was more expensive relatively than the non-Baltimore area. Again, by about $44. And now I want to emphasize that the prior slide was about unadjusted costs. This slide incorporates the risk score and benefit adjustment. And it's really showing the same, these same values, but in a figure to kind of graphically highlight some of these points. So what we see here are for both the Baltimore area in Maryland and their respective benchmarks, and the non-Baltimore area, again in blue, and then the benchmarks in gray. We see that, again, both the Baltimore area and the non-Baltimore area were less expensive on a total allowed cost per member per month on average than their benchmarks by $50 or $70, roughly speaking. And that's after risk and benefit adjustment. But that the Baltimore area after risk and benefit adjustment remains a little bit more expensive than the non-Baltimore area by $14.99. And so that's kind of a major top line finding of this study, is that Baltimore is more expensive on a total allowed cost per member per month on average than the non-Baltimore area relative to their respective benchmarks by $14.99. Okay, so now we can we decompose differences in allowed costs between the Maryland and the benchmark areas. And that's what this slide shows. And so we did that by identifying the extent of variability due to differences in underlying unit costs and utilization. So this analysis calculates the extent that these two factors contributed to any differences in terms of the total allowed cost per member per month. So all these units are no longer in units of unit cost or utilization. They're all in units of total allowed cost per member per month, so that we can really see kind of on an apples to apples basis what's driving this difference. So again, in this, I see a few comments in the comment screen, and I think we'll take those at the end, but do look forward to the Q&A. So in that first column, we see the finding that was presented previously, that both the Baltimore area and the non-Baltimore areas were less expensive relative to the benchmark, but the Baltimore area was about $15 higher on a relative basis. And now moving into the contribution to variation analysis, we see that the Baltimore area was about $37 more expensive than the non-Baltimore area on unit costs, but that it was a little bit less expensive on utilization. So $37 more expensive driven by unit costs, and that's offset by about $22 from lower utilization. And so that's kind of the other thing, another major finding here, that higher unit costs in Baltimore are driving this difference that we see of about $15 total allowed cost per month. So this exhibit shows differences in total allowed costs between the Baltimore and non-Baltimore areas overall, and for groups of line items. So the overall finding that I've been talking about is highlighted in the box. And each of the line item groupings that Oswaldo mentioned in his methodological overview are presented below. So again, in light blue, we have these total allowed costs per member per month. Differences between these two areas, between Baltimore and non-Baltimore relative to the benchmarks on average. So those light blues are kind of the main overall finding. And so in the box, we see the $14.99, where Baltimore is more expensive than non-Baltimore relative to the benchmarks. And then in purple, we see the contribution to variation from utilization. And in that orange, dark orange or brown, we see the contribution to variation from unit costs. So again, what we see here is slightly higher total allowed cost of care in Baltimore relative to non-Baltimore areas, relative to the benchmarks, driven by higher unit costs in Baltimore. Now working through each of the line item areas, we see higher total allowed costs on average of about $8 in the facility inpatient setting. Driven by higher utilization in Baltimore relative to non-Baltimore in the benchmarks, and in facility outpatient subtotal in the facility outpatient setting, we see higher total allowed costs on average of about $24, $25, driven by higher unit costs and higher utilization. And in the professional setting, we actually see lower costs on average in Baltimore relative to non-Baltimore in the respective benchmarks of about $18, driven by quite a bit lower utilization. And so these are the major findings here. The other professional and the additional benefits categories are quite small, and so we don't really discuss them too much. But just to emphasize here, so the largest difference that's driving our findings really is that facility outpatient setting, and so we'll go into detail in facility outpatient a little bit more below. And so this slide does that. So due to the finding on the prior slide, we further analyze what facility outpatient sub-line items could be contributing to the total allowed per member per month cost difference between the Baltimore and non-Baltimore areas relative to their benchmarks. Facility outpatient services include services such as for the emergency department, outpatient surgery and radiology, as well as a number of other things. However, out of the 14 line items in our analytic data file that we were able to look at, the one where we found the largest differences was called other outpatient facility. So kind of a hodgepodge of things. And other outpatient facility accounted for about half of the difference that we were seeing in this setting between Baltimore and non-Baltimore areas. And at the bottom of this table, you see $10.45 out of about $24.54 in total for facility outpatient, where unit costs seem to be, this is not the contribution to variation, this is just the average difference. But unit costs seem to be telling the major story here. And so drilling into this other outpatient facility category, dialysis services comprise over half of this category spending for both the Baltimore and the non-Baltimore areas, and preliminary analysis indicates that unit costs for dialysis services were almost twice as expensive in the Baltimore area than the non-Baltimore area. Again, this is kind of a drill down back to the envelope analysis, but I do think it could be suggestive for further research or inspection otherwise. So that's kind of, definitely one single factor that we were able to find that is at least accounting for some of this difference between these two areas, we think. So now we're gonna kind of switch directions. The majority of this discussion has been for the commercially insured, employer insured population. This slide, this is our only slide for Medicare fee-for-service population. We conducted a similar analysis using Medicare fee-for-service data, mirroring the analysis of using commercial data discussed above. After risk adjustment for HCC mix, the difference in the total per member per month cost between Baltimore and non-Baltimore relative to their respective benchmarks was $197. Again, more expensive in Baltimore relative to non-Baltimore on a per member per month basis on average, per beneficiary per month. And so notably here, we do not see the same patterns where the Maryland areas, Baltimore and non-Baltimore, were less expensive than the benchmarks. In contrast, both areas were more expensive. Oh, that's not true. Baltimore was more expensive than the benchmark, and the non-Baltimore area was roughly comparable to the benchmark. So some slightly different patterns. And so this difference of $196.97 in total at the bottom right of this table represents a 17% relative difference when compared to the average total per beneficiary per month cost. So it's quite a large difference. And unit costs and utilization contributed roughly equally to this higher total costs in Baltimore relative to the non-Baltimore area, again, relative to both benchmarks for Medicare fee-for-service.
Okay. Thank you, Sean. Have we gone through a lot of details, so then I'm going to try to have a kind of a little bit of summary of our presentation. There are three takeaways I think that we have from today. First, and I think it's important for us to keep that on the forefront, is both Baltimore area and the non-Baltimore area have lower per member per month allowed costs than their respective benchmarks. I think we saw that consistently across all the presentation, so that's very important to keep in mind. Second, Baltimore has a higher per member per month cost of about $15, or about 4% of the total allowed cost per member per month cost relatively to the non-Baltimore area, and this is net of the benchmark adjustments. Because there is still potential savings to be addressed in Baltimore area, which could be of a magnitude of $73 million. One thing that also is important for us is where is this cost difference coming from? Well, you see from higher utilization and from what hospital services. The decomposition analysis confirmed that utilization is lower in Baltimore than the non-Baltimore area. So the focus is on the unit per member per month cost. And the group and subgroup item analysis provided a guide for where the areas that need a little bit of attention. Well, we saw a cost from other outpatient services, and in particular, dialysis services seem to be a potential source for the higher total allowed cost relatively to the non-Baltimore area. It is possible that the reductions in healthcare spending for the commercial and insured population from the Maryland all-payer model and the total cost of care model have accrued unevenly across the state, despite the great gains that I have had on the first year. One thing in terms of the discussion would also be that there are some limitations here. Well, obviously the cost profiles that we calculated by adjusting total cost and utilization measures are at the top of the total score. They're not done at the group or subtotal line items. When we're referring to the difference in outpatient services and dialysis, for example, that's not been accrued. We're doing at the highest level. So there might be something else happening that if we were to dribble down and use the same approach for those, something might be different. The outcomes might be different, but that's just one limitation on the analysis on the cost profiles. And in terms of the Medicare analysis, we had to use inpatient admissions as the utilization measure, since we did not have access to the RVUs. So utilization in the outpatient setting may not be as accurate as we would like to. And that's all the information that we have in terms of a presentation. I see that there is a few questions. So I'm gonna thank you for listening to us and kind of going through all these little details from this study. Sean?
Yeah, I think maybe we can just flip to our questions page. Yeah, and then I guess we'll turn it over back to Chris. How would you like to proceed? We can answer some questions or whatever's helpful.
Yeah, thank you, Sean and Oswaldo. And I'd like to thank everyone again for being here. We really appreciate this presentation. This has been recorded and it will be available on the CRISP Learning System website. And the actual full report is already available, so we will get that link dropped into the chat. And I can start reading off the questions. So our first question from Vivian is, was the non-Baltimore area data broken down by urban, suburban, and rural areas?
So Oswaldo, can you actually flip to the slide with the map? So we were using data that was structured at the county level here. And so importantly, and I think this maybe relates to one of the other questions, we defined the Baltimore area according to counties that we identified as being in the Baltimore area. This is through conversations that we had with our project officers at the HSCRC, as well as with some analysis that we did of demographics on average in these counties. And so the Baltimore area consists of Carroll, Hartford, Baltimore, and Baltimore City counties. And the and for the non-Baltimore area, we really wanted to focus on other urban areas that were kind of not immediately in that Baltimore region. And so they tended to be more in the suburbs of Washington, D.C. These included Montgomery, Prince George, and Anne Arundel. What we didn't want to do is compare Baltimore to some of the more urban areas, for example, on the western side of the state. Does that answer the question? And so ultimately what we're doing is we're taking, yeah, great, thank you so much, is we're taking an average, a weighted average of costs in each of these counties, weighted by the population size in these counties. To roll up to the Baltimore area estimate and the non-Baltimore area estimate.
Thanks, Sean. Our next question is from Thomas, and he's asking, so are the findings cost by line item groups saying that Baltimore has higher costs for facilities and much lower costs for professional services? And was this only for people with private insurance?
Can you please go to that slide, Oswaldo? The answer is yes, you got it. That was a great summary. A couple more. We want to go. Yeah, perfect. Excuse me. Exactly. Forgetting who raised the question, but you summarize this finding perfectly. So we actually see lower total allowed cost per member per month in Baltimore relative to non-Baltimore areas in the professional setting. And this is driven by lower utilization. We're just reacting to this question. I do have a response, but we'll go in an orderly fashion. And I guess just to the individual who asked this question, does that answer your question? Great. Thank you for the question.
Thanks. And our next question is from Aaron, and they're asking, is it safe to assume that this is based on member residence? So if a patient lives in Montgomery County but receives care at a Baltimore hospital, that spend would be picked up in the non-Baltimore area bucket?
That's a good question. I'm honestly not sure. We would need to look at that. I'm not sure. You know, if this is something that it would be helpful to know, we can look into this and get back to you.
Thank you. So our next question is from Christine. They are saying, how is Baltimore versus non-Baltimore defined? Is it based on the address of the person or where the healthcare utilization occurred? If it's the member's address, how do you account for seeking services outside of the residence area, such as seeking care in a hospital outside of the county of residence?
Again, we would need to double check on this. I hesitate to say this because I'm not sure, but I have an inkling that it's about where the utilization occurred. But again, I can double check. It's a good question.
Okay, thanks. And then our next question is from Aaron. They're saying, do you think that grouping Baltimore City with the surrounding counties dampened the magnitude of the difference? Just wondering if you were able to see which of the counties drove the results.
Yeah, we don't have a slide for this, but I do think that I think you're right. Per member per month, total cost of care on average were more expensive in Baltimore City County than the other Baltimore areas. But you know, the geographic region there is quite limited, and I think we saw at least some similar trends, especially in Baltimore County. So yeah, it is possible that including some of those other counties in that region dampened the area, but we wanted to make sure that that we were including kind of the Baltimore area more broadly, not just focusing on such a small area, in particular because of some of these travel considerations that folks are discussing.
Thanks, Sean. And it looks like that was our last question. We can hang on if anybody has any last questions in the next few minutes. But otherwise, thank you, Sean and Oswaldo, for this presentation today.
Thank you so much for having us. And I think our contact, I'm not sure if our contact information is available, but you can find us, I believe, or if not, certainly CRISP folks have our contact information, and we'd be happy to chat about this. As well, you know, our project officer for this report is William Henderson, so I'm happy to volunteer him as well.
Hey, Sean, this is Aaron. I appreciate the presentation. I do think it would be helpful to confirm whether the spending was calculated based on area of member residence versus where the care was received, simply because if it's based on where the care was received, you certainly would expect greater utilization in the Baltimore area, given the number of facilities, right? And I think what we're trying to do is determine the differential impact on people who live in certain communities. At least that, I don't know, maybe that wasn't the intent, but I think the way that was calculated will be critical in how we interpret this study.
Loud and clear. How can I get back to you, Aaron?
I will shoot you a note offline.
I'm going to put my email into the chat.
Perfect. Thanks.
And hi, everyone. This is Jessica. Sean, when we make that determination, it might be nice for us to know as well, and we can actually post it on the learning system where the final report and a copy of these slides are also housed.
Okay. I will loop you in, Jessica, to my response to.
Thanks.
And then we do have one last question. It's from Thomas, and they are saying, is there any way to consider the percent of the population with private insurance plays into this? I'm assuming Baltimore City County has a pretty high level of uninsured as compared to the other counties.
I think this is a good question, Thomas. I don't really have a response to that. But no doubt, there are some different cost structures at play here. We analyze the total allowed costs in the data. So we can't speak to the uninsured populations, but in terms of what commercially, what employer insured populations we're spending on costs, what insurers, what payers we're allowing as costs, this is what we see.
Thanks. So we actually did have another question. It's from Dan. They're saying, did they perform a difference in difference analysis to control for population differences in the utilization and cost analysis?
Yes, and so it's not a classic difference in difference study. It's but we do these two. It's not like a regression model where we're running a difference in difference analysis. This is more of an actuarial approach. But yes, on slide 12, I want to say, where we look at the contribution to variation analysis, those are for the Baltimore area relative to the benchmarks, and for the Norton Baltimore area relative to the benchmarks. Those are kind of differences that we're looking at. If that makes sense, and then in relative to the Baltimore and non-Baltimore areas as well. That second difference.
Thanks, Sean. So that looks like that was our last question, but Sean did put his email in the chat if anyone wants to reach out with any additional questions. Also feel free to reach out to us at CRISP. I wanted to thank everyone again for coming to this presentation, and this will be recorded and put on our website. Thank you guys so much.
Thank you. Thanks everyone for coming.